We are live in the Lyme disease UK Facebook group with Dr. Lambert. Dr. Lambert is a consultant in infectious diseases in Dublin. He qualified in New York State and was involved in evaluating and diagnosing many Lyme disease patients during his time there. He now is back in Ireland and practicing as an infectious disease consultant, and also has a private practice managing Lyme disease and co-infections with his patients. So welcome, Dr. Lambert. It's great to have you here. Thank you for sharing your time with us.
Okay, thank you.
So I guess the first place to start would be, how did qualifying at New York State give you an advantage over practitioners in the UK and Ireland in terms of recognising and understanding Lyme disease?
Well, I think it's just there's more there's more awareness of Lyme disease because if you look at where Lyme first started in the states of the Union in America, it's Connecticut, New York State, Maryland. Those are the states that were primarily first affected. So I just saw more cases of Lyme early in my infectious disease career than I think most of the infectious disease doctors in UK and the infectious disease doctors in Ireland, and in fact, if you're in America, a lot of primary care doctors also have an awareness of Lyme as well because they see the patients if they're in Lyme endemic areas.
Of course, of course. And I guess you must have been exposed to the IDSA viewpoint, and I'm aware you recently presented at ILADS this year. How do you navigate between the sort of two organisations' quite different stances?
Right. Well, see, I don't. I'm a member of ILADS and I'm a member of Infectious Disease Society of America, but you see, we're all practitioners. We all take care of patients. You see, so the guidelines are guidelines. But if you have somebody coming in with an infectious disease, you don't actually practice guidelines. You practice medicine. So there's no issue with me in terms of ILAD guidelines, IDSA guidelines. You actually you kind of establish your own model of practice based on your cumulative knowledge, your cumulative experience, and also managing the patients. So like I said, there are differences, there are issues, but when you're a member of a professional society, Infectious Disease Society of America, the International Lyme, kind of an associated disease group, they're just basically for me a network for education, for CME, for opportunities and dialogue.
Yeah, that makes sense. Um, so I guess moving on to how you practice and how you approach it, Lyme disease can be quite difficult to diagnose, as we know. How do you go about which test you use at different stages of the disease, and making that diagnosis, and why?
Right. Well, that's it's not that simple a question, to be perfectly honest. I
Indeed.
guess stepping back, the tests that we have for Lyme at the present time are imperfect. And then the awareness that when you get a tick bite, sometimes it's not just Lyme. You can get other infections, Bartonella, Babesia, Anaplasma, Rickettsia. There's lots of different things you can get from a tick bite. So the very beginning is that what are the standard tests for Lyme? Well, the standard test, according to IDSA, is the antibody tests. But we all know that antibody tests are not 100%. So Lyme to me is a clinical diagnosis,
Uh-huh.
uh, and the testing, Lyme testing, co-infections testing, autoimmune testing, inflammatory marker testing, lymphocyte subsets, immunoglobulins, those are all tests that you use in combination with the history, in combination of the patient in front of you, what symptoms they have. So you put the pieces of the jigsaw puzzle together and you make a clinical decision, but you don't hang your hat on. And this is where I think patients are failed, is that if you don't have a positive test, you don't have the infection. That's absolute nonsense. That doesn't apply for any medical condition in the world. If somebody comes in with chest pain to the emergency room, you kind of you and they're in the risk group, you go ahead in an emergency, you treat people. You don't say, well, we need to do an ECG, we need to wait for the cardiac enzymes to come back. If you wait that long in an acute medical situation, the patient's dead. So by analogy, if you've got a patient with Lyme disease and they're acutely unwell and they've got a rash, the guidelines are you don't need an antibody test. You need to treat them. If the shoe fits, wear it, you know. So this is the standard of care. The standard of care should be in early Lyme disease, you should treat if the history and the examination fits the clinical picture. We do that for all sorts of other conditions, and we should do the same for Lyme. So that's acute Lyme. In terms of chronic Lyme, there's still that debate. People deny there is such a thing as chronic Lyme. Of course there's chronic Lyme, but what are the optimal tests? We don't know. So we need better research. You know, what happens to the antibody tests? If you have somebody who has Lyme and it's gone into a chronic persistent stage, what happens with the antibody? Maybe it never goes positive in the first place. Maybe it goes positive and then goes negative. So you're asking me the question is, what's the optimal test for different stages of Lyme? We don't know because we're too busy debating that you can't treat Lyme unless you have a positive antibody test, or there is no such thing as chronic Lyme. So I think what we need better research. We need better diagnostic tests, and we need to understand this disease better. So we need a bacteria-specific test. Back in the olden days with HIV, we knew people were sick, and we knew their lymphocytes, their CD4 cells were low, but we didn't have an HIV viral load. Now we use an HIV viral load to assist in evaluation and treatment of HIV. I think we need to have a good diagnostic test that is bacteria specific, that actually isolates the bacteria. If you have a positive bacteria test for Lyme, then all the debates about antibodies, alternative tests would go out the door. In the meantime, we don't have optimal tests, and I think we should be treating patients clinically. And when the tests are positive, whether they're immunological tests, antibody tests, LE spots, other tests, that they're positive, then they can be helpful in the right if you take the right history and do the right examination and do all the other tests. But if they're negative, they're not 100% sensitive. So they can miss patients. So I think you should be treating the patients ultimately and using all of the pieces of the puzzle that you have, clinical, laboratory, history, to assist in making the appropriate diagnosis and come up with a recommended treatment.
Absolutely. I guess we can live in hope that will spread to more doctors. It'd be a good time actually to ask. I don't know if you've had a chance to see the NICE guidelines, the draft that was published. I don't know if you have any thoughts on those. If you have.
Well, not really. I've been trying to avoid looking at things that I mean, very simply, if people are going to sit down and say the antibody test is the only test that we use, and if the antibody test is negative, you don't have Lyme, I think that's a mistake. If people, I've done my homework and looked in the literature. There's lots of data that patients can have Lyme, and you can isolate the Lyme bacteria. In research studies, you can isolate the Lyme bacteria months and months and years down the road and from patients' tissues. So Lyme can persist for a long period of time. There's animal studies done by the NIH where they treated animals, rhesus monkeys, with standard antibiotics. These were monkeys that were infected with Lyme, and even after intravenous ceftriaxone, standard oral treatments, months later, when they sacrificed those animals, they still were able to isolate Lyme from the joints of the animals. So we've got data that there is such a thing as chronic persistent Lyme. And if NICE guidelines are going to come up with saying our test, the standard antibody test, is the only test, there is no such thing as chronic Lyme, and short course treatment is the way to go, there's lots of data out there that contravenes that. Mm-hmm. I think we shouldn't be getting into this boxing match with people in one corner and people in another corner. I think we actually have to listen to patients who say, I've been sick for a long time, I've not been treated appropriately, and when I am treated, and I'm treated for a longer period of time, I get better. That is a message that doctors should be listening to. So I think the NICE guidelines are I don't know why we put together guidelines that are just aimed at putting people in corners, polarizing people, rather than bringing them together. So it is a very complex disease. Lyme is a complex disease. Chronic Lyme is a complex disease. Co-infections are a complex disease. But to stand around and say there's no such thing as chronic Lyme, there are no co-infections, is only putting the patient in the middle and not getting them the appropriate treatment they need.
Indeed. And you mentioned around tick bites and also HIV, and I guess that brings me on to what are your views on whether Lyme can be transmitted either congenitally or sexually?
Well, I think how common. So first off, of course, it can be transmitted sexually, and of course, it can be transmitted by vertical transmission. The question is, how common does it occur?
Yeah.
That's the issue. If you're a pregnant woman and you get bitten by a tick in your pregnancy, then that's the period that the bacteria is circulating in your bloodstream, and you're highly infectious at that stage. But that's not unique to Lyme. That's true with all diseases. If you're a pregnant woman, you've had Lyme for 10 years, and the bacteria is kind of in your tissues, and it's causing damage to you, but is it going to be in the bloodstream, and is it going to be spreading from the mother to child? I think it's highly unlikely. So the issue is not, is it transmissible or not? I think we have to understand when it's highly transmissible and when the transmissibility risk is very low. So I think it's if you've got chronic Lyme, when it's very hard to detect the bacteria in the bloodstream, I think it's very unlikely that you're going to get mother to child transmission, and it's very unlikely you're going to have transmission from male to woman, woman to man, from sexual transmission. But the risk is not zero in any situation.
Mm-hmm. Mm-hmm. Thank you. And with chronic Lyme disease, so you've mentioned there someone that maybe has had it in their system for 10 years. If you've got a patient like that, they've maybe been misdiagnosed or symptomatic, and they've not got to the bottom of it, and they've recently found out that they've got Lyme disease and some co-infections.
Mm-hmm.
Do you believe it's possible for those people to return to good health through antibiotic or other treatments?
Well, I think it is. I mean, the challenge, people say that, oh, you've had it for 10 years, it's no longer there. This is post-infectious. We still get back to the point. An antibody test is not an infection-specific test. It's an immunological response that says you've been exposed to the infection or you have the infection. So all the tests we have right now, ELISpot assays, antibody tests, you have to then say, is there still active disease? And that's where the debate lies. But I see patients who have been probably infected 10 years before. They come in with an antibody test that's positive, or an alternative test, an ELISpot assay that's positive for Lyme, and I put them on treatment, and they get better. So by using my clinical decision making, which I make all the time for other conditions, I treat patients for prostatitis, I treat patients for ear infections. And they may have these conditions for a long period of time. You don't say, oh, it's post-infectious because you've had it for 2 months, you've had it for 6 months, you've had it for 3 years, 4 years. There can be chronic persistent infections. In that situation, you can't prove that there's infection. My proof is you put people on antibiotics and they get cured. That is the proof that you need. So I think chronic persistent Lyme can go on for years and years. And I think even if it's 10 years down the way, I have patients who have 100% recovered on the appropriate combination of antibiotics for a longer period of time. So I think short course antibiotics may work in the first, month of an infection before it disseminates. But in the chronic phase, I think you can cure people, but not with the standard treatment guidelines as they currently stand, according to IDSA.
I'm sure that will give our members lots of hope if they're in that situation. So thank you. And in your treatment approach, do you see that there's a balance between infection, inflammation, immune effects, so that there is, it's more than just the infection? And if so,
Yeah,
how do you
absolutely.
approach that?
Absolutely. There's three things going on, and that really is it. You get an infection, the infection damages your immune system, and then your immune system starts, operating in a dysfunctional way, even overworking or underworking. And then you get, in response, all of these inflammatory cytokines and chemokines being released in your body. So there's three things: infection, inflammation, and autoimmunity. And when I first treated patients with these conditions, I kind of thought if you just killed off the infection with antibiotics, that would do the job. But then you listen to your patients, and patients say, well, doctor, I'm also taking these other supplements. I'm also taking these alternative treatments. And I think these alternative treatments build up your immune system, decrease the inflammation, and then that allows the antibiotics to work better. So it's a complex interaction of infection, inflammation, autoimmunity, and you have to deal with all three. So there's lots of people that say, that people are going to get better with these alternative immune therapies. I think they're critically important, but I think the only way you kill a bacteria is with antibiotics. But you don't kill a bacteria if you have a weakened immune system. So a multi-dimensional treatment approach is critically important for these conditions.
Absolutely. And do you ever find that IV antibiotics are required, either because orals haven't been sufficient, or because someone can't tolerate orals?
Well, I think the only situation is people kind of are on this, I need IV antibiotics, I need IV antibiotics. Well, if you've got acute Lyme and you're sick in the hospital with meningitis, probably IV antibiotics probably get better penetration into the brain. But I think in the chronic phase, all of the antibiotics we use have good tissue penetration. So as long as your gut's working and as long as you can absorb, I think there's no reason for most patients to go to the IV route in the setting of chronic Lyme, as long as they can tolerate the oral antibiotics. If you're getting recurrent diarrhea, if you've got malabsorption, the only way you can get the antibiotics in is through the IV route. There are exceptions, but I think people push the IV therapies too much. I think oral therapies that patients are absorbing work just as well.
And obviously far more convenient as well for people.
Right, long term. And also it's dangerous, I think. If you have an intravenous catheter in for months and months, the catheters get infected, and then there's 10% of long-term intravenous catheters become infected, and then you get a secondary complication. So you shouldn't be, oral antibiotics give you diarrhea. That's a risk. But most patients don't get diarrhea if you give them probiotics and lots of supplements. So it's much safer, I think, to go the oral route than the IV route. And it's much more practical, less expensive, and I think it works just as well.
Great, thank you. What's your approach, and what do you use drugs, or do you expect people to use supplements to reduce the inflammation? I know we've touched on that a few times.
Right. Well, there's all these. I mean, people have all these. There's all these different approaches to supplements. So there's all these different companies that make the supplements. So everybody has their favorite company, and we don't know what supplements work the best, to be perfectly honest. And then there's all these alternatives. There's low dose naltrexone, which I think is incredible in the right situation, but some people don't tolerate it. So an awful lot of the adjunctive therapy is a bit of trial and error. I think probiotics and kefir, those kind of things kind of help the gut, tolerating the antibiotics, but also your immune system is largely in your gut. So patients actually improve their symptoms. Some of the autoimmune and inflammatory symptoms improve just on good gut protection. So I think there's lots of different approaches. Antibiotics are critical to killing the bacteria, but probiotic supplements, LDN, and all of these different protocols that kind of help build up the immune system and decrease the inflammation, they're important, but everybody's different. So I don't think we should have protocols. We should actually really have people are not protocols. People are individuals, and some individuals tolerate LDN. Some people tolerate one antibiotic but not another antibiotic. So I think you really have to individualize the care for these patients because they are very complex conditions, and we shouldn't be trying to simplify it. We should be trying to individualize it.
Yeah, yeah, of course. One member asked about sleep. It seems to be a common issue with Lyme disease patients or those with co-infections.
Mm-hmm.
What are your thoughts on sleep? What happens to cause that insomnia, and what can maybe people do to get some relief?
Right. Well, if you think chronic Lyme, if you got Lyme in your joints, you get pain. So people, it's migratory pain, moves around, but people get pain. I think if you get Lyme in your, Lyme goes to the nerves, Lyme goes to the brain. And co-infections do too. And it's almost a subclinical inflammation. So if you've got inflammation in your brain, you've got sleep disturbances, personality disturbances, concentration problems, fatigue, exhaustion. All of those are part of the inflammation. And a lot of those get better with treatment. But if you're tired and you're waking up tired, your immune system's weak. So you're taking all these supplements to build up your immune system and you're exhausted when you wake up. So I think it's really important to balance to wake up rested. And if you take some of the sleeping pills, they're addictive. And I think some of the natural remedies that my patients have taught me, things like melatonin, things like tryptophan, I think are really the way to go. They're safe and they work most of the time. So I think taking melatonin, taking tryptophan, getting your sleep your sleep pattern in order so that you get a good night's sleep is critically important to building up your immune system. I use the analogy herpes cold sore virus. People have the herpes cold sore virus in their system, and when they're exhausted and run down or they're stressed out, it flares up. You take a weekend off and rest and get a good night's sleep and get away from the stress, and the herpes virus goes away. So it's a fight. Infections and your immune system are in balance. So sleep is critically important. So melatonin and lots of it is kind of is the natural way that my patients have told me works, and I recommend it to them, and it works for most of them.
Thank you. And one member asked around what could cause sex hormone deficiencies in a patient with Lyme disease, and what would you do about addressing it?
Well, the thing is that if you have a bacteria that gets into your bloodstream and goes to every tissue of the body, it probably goes to the endocrine organs as well.
Mm-hmm.
So you see patients who have Lyme and co-infections that have thyroid disorder. So I think the bacteria gets in, spreads to these organs, and then they cause endocrine dysfunction. We can't prove it. We need better research. So I think you actually have to treat patients, and a lot of these disorders reverse themselves. In the meantime, you have to sort of support them. If your thyroids are low, you have to give thyroid replacement.
Mm-hmm.
If your other sex hormones are low, you also have to support those as well. So that really is I think these are multi-system diseases, and I think they affect the endocrine system, neuroendocrine system as well. So I think it's just part of the whole disease.
Thank you. I'm conscious we've only got you for a few more minutes. So,
Mm-hmm.
given we've spoken quite a lot about treating the individual, treating the patient, have you any advice for patients as what they can do to put pressures on government and the powers that be in order to help us enable that sort of proper care that we all need?
No, I think it's quite a challenge because you've got, it really is a challenge. I think there's a lot of people within the system that just have this traditional view. This is Lyme, this is the antibody test, short course treatment.
Mm-hmm.
But I think I think the best advice I have to my patients is get better and then get on with your life, feel better about your life, or go get involved in meeting with your local MP. Or if you get better, go back and talk to your GP and say the GP at one time may have had a view that there's nothing there. Once they see people getting better, sometimes GPs are actually more open next time around if they see a few successes. So I think everybody should do something once they're better, having been treated for Lyme, having gone through the experience. Sometimes it's just talking to an MP. Sometimes it's advocacy. Sometimes it's join special groups. So there's no right solution to this. It's your decision, but there's a lot of work to be done. and you just win people over one at a time. I think that's the way you go about it. I think it's a real disease. I think there's lots of gaps in our understanding of this disease, and there's lots of politics that we have to overcome. But I try not to get involved in the politics. I try to take care of the patients and actually encourage them once they get better, and many of them are getting better, to help with the effort as well.
Brilliant, thank you. And then a very final question that we always ask everybody. We've got lots of members, and what would you say to someone who feels that there's no way out?
Well, all I can tell you is that I'm an eternal optimist. I was around early in the days of AIDS when everybody was dying, and I've worked in the last number of years in hepatitis when everybody was dying, and I think we're in a better situation than we were a few years ago. So I think we are, So I would say, if you're not getting the right answers, go talk to somebody else. Don't. If you know you're right and you know your body and you know there's something wrong, and people are telling you there's nothing wrong, if the tests are all normal and the doctor says there's nothing wrong with you, the problem is they haven't done the right test, or we don't have the test yet developed to come up with appropriate diagnosis. So push that argument. Don't say, a negative test means there's nothing wrong with you. A negative test means somebody hasn't done you justice. So just hang in there. That would be my advice.
Brilliant. Thank you very much. And thank you very much for your time today. It's really appreciated.
Okay. All right. Thank you.
Lovely.
Okay. Bye-bye.
Bye.